So I'd like to invite Dr. Muna. Dr. Muna is a wonderful teacher of all of ours and one of the finest minds in medical retina in this country. Dr. Muna, please. She'll be talking to us about the algorithmic approach and analysis in dry age-related macular degeneration.
Good morning, everyone, and thank you for being here, and thank you, Uni, for this opportunity. We know geographic atrophy evolves from normal aging to certain features at risk, and finally clinical geographic atrophy, which causes a loss of vision. So my talk will be just to, I can't see this slide if you put this in the way, yeah. So my talk will just to tell you which are the features that we need to look at to predict progression of geographic atrophy. Now really, how significant is it in Asia? There was this study by the Asian Eye Epidemiology Consortium where they showed that the geographic atrophy actually had a lower incidence than the West. But if you look closely at the data, there were studies from South India which showed the geographic atrophy was actually a little higher, but they had to exclude them during the sensitivity analysis for lack of certain information. And most of these studies came from India, which shows that probably we don't have such low an incidence of geographic atrophy as the world thinks. And this is a table which shows us that there are various predictor models for ARMD and especially geographic atrophy. What is most important, there are numerous factors like age, education, smoking, and the genetic risk score, and also the severity scores at baseline and the fellow eye, and all these could be predictive of progression of the disease. And I think nothing describes geographic atrophy better than this article, which tells us we really don't know much about it at all. We don't know when it comes, but we know it progresses. How to stop it, we are not sure. And this table tells us that there are few shared criteria which tell us that incidence and progression can both be predicted. And most important is the genetic makeup of the individual, and I'll show you a slide later. Cigarette smoking is a well-known risk factor. The Mediterranean diet, but not its content, is a protective factor. And certain phenotypic features like reticular pseudodrusen and hyperreflective foci. Interestingly, there are certain factors that are totally contradictory when it comes to incidence versus progression, and the role of AREDS as well as complement inhibitor is still uncertain. This is one of my patients whom I diagnosed choroidal neovascular membrane in the left eye at the age of 41. I noticed he had drusen in the right eye. He's now 57 years old, and this was his fundus picture a couple of months ago. We had a project running on genotype in patients with AMD, and this actually was his genotype. He was homozygous for the ARMS2 gene, the HTRA gene, and the CFH gene, and the C2 gene. Why is it important? Because these are all risk factors. And another thing, why did he develop it so early? Because he had multiple homozygous risk factors. So if you see a patient with drusen at an earlier age, they are more likely to develop clinical geographic atrophy later on. This was a large US, UK-based cohort, which also told us about progression from early to intermediate to advanced forms. And they found that the status of the fellow eye also influences the rate of progression. One eye with GA, you know the other eye is going to go in for GA. And this was their table. And then part of the AREDS2 study was also to look at OCT risk factors of GA progression. What was significant is the presence of RP atrophy showed a very high incidence of progression of geographic atrophy, whereas absence of RP atrophy at baseline, the incidence of progression was much lower. What are the precursor lesions and how fast do they progress? Large confluent drusen, relatively slower, almost over a period of 6.5 years, whereas hypopigmentation seen as atrophy and hypertransmission on OCT can progress as fast as 2 to 3 years to geographic atrophy. How can we image these cases? Color fundus photograph. Autofluorescence is something most of us are familiar with. Quantitative autofluorescence, probably most of us don't do it yet. Infrared multicolor imaging, and as well as OCT. The various OCT factors for progression. A large volume drusen, so the large drusen can sometimes collapse and cause atrophy. This eye has not caused atrophy. Here you see the collapse, but there's still some deposition of material. Over a period of time, we expect that to progress to atrophy. Hyperreflective foci over the drusenoid pigment epithelial detachment eventually leads to atrophy. And there are certain changes which are at high risk, that is change in the character of the internal reflectivity of the drusen. Here you see hyperreflectivity, and you have the hyporeflective core. Again, hyperreflective foci, and interestingly, outer retinal tubulations, which we all thought were atrophy, where if you see it at the border of the area of atrophy, it's believed to be protective and protects it against progression. And I think most of us would have seen these in our cases, a large pigment epithelial detachment developing hyperreflective dots on the surface. Over a period of time, you see the content changes and ends up as atrophy. Usually takes about 4 years. Other known risk factors are reticular drusen, pseudodrusen, and calcified drusen, best picked up on fundus autofluorescence and near-infrared imaging. And we've all known that the CAM study group gave various risk factors for progression to geographic atrophy. What are the high risk factors are incomplete retinal pigment epithelium and outer retinal atrophy, such as iRORA here. Nascent geographic atrophy, where you see subsidence of the inner nuclear layer progressing to more atrophy over a period of time, and this is a 2-year period. And this was the study which showed the OCT findings of incomplete outer retinal atrophy progressing to complete outer and retinal atrophy. Here you see a uniform area of hypertransmission where there is intermediate irregular areas of hypertransmission indicating this is incomplete and this is complete, and this is a major risk factor for GA. Looking at the edge of the geographic atrophy, what do you see on the OCT edges? If you have a smooth edge like this, the risk of progression is less. But if you have an irregular edge like this, or if there is splitting, the chances of progression is much higher. Autofluorescence, we all know, is a very easy way to study atrophy, and there are various patterns of autofluorescence. The banded and reticular diffuse pattern is more likely to progress to GA. This is one of my own patients whom I'm following for a period of years. If you look at the autofluorescence pattern here, and you look at the autofluorescence pattern here over about 2 years later, you see that the area of autofluorescence is definitely increased, and there's some patchy abnormalities at the border, and you look at this hypertransmission on the B-scan OCT. And this was his other eye. Again, you see this was at presentation. This was a couple of years later. There is an increase in the area of atrophy. Various risk factors that are at high risk for atrophy. You have multiple areas of autofluorescence abnormalities, multifocal, extrafoveal is more at risk of progressing, and then you have patches like diffuse, banded, and diffuse trickling patches of hyperautofluorescence, which can cause a high risk of progression. In addition, thin choroid can also cause progression. And these are the various risk factors which are well known to cause progression of GA. This is a patient over a 72-month period showing the progression of atrophy. Can also be seen as choriocapillaries abnormalities. The CVI is also associated, but this is more of a research tool right now. And of course, AI will help us to correlate what we know already and maybe apply it to a larger data set. So I don't have an algorithm because there's not much to say in that, but these are the red flags if you see a patient with drusen. If the patient is younger, possibly carries a genetic risk factor, so the risks are higher. Environment like diet and smoking is easily adjustable. There's certain phenotypes like large drusen, reticular drusen, extrafoveal GA and GA in the fellow eye, which are at high risk. Use various imaging modalities to identify and monitor these patients. Look at biomarkers like the pattern of AF changes, the edge and the focality, and also OCT and drusen size. Thank you very much for your patient listening. I welcome you all to Chennai in July for our meeting. Thank you.